Hello friends, today we are going to discuss about electroconvulsive therapy during perinatal period. That means ECT during pregnancy and postpartum. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMANS, Bangalore. In this video, I'll be discussing about what is perinatal period, ECT during pregnancy and postpartum period, what are the indications and side effects, what are the laws regulating electroconvulsive therapy during perinatal period. Let's understand what is this perinatal period. Perinatal period is a time when a woman becomes pregnant and up to a year after giving birth. It has two important periods, antenatal period and postnatal period. Antenatal period is also called as prenatal period, that is before birth, that is from the time of conception to the birth of the child. Now, what is postnatal? It is also called as postpartum, that is meaning after the birth, that is from the time of childbirth to the 1 year after the birth. Perinatal includes both antenatal and postnatal. Let's discuss about pregnancy and mental illness. Mental illness are at high risk of relapse during pregnancy. Not only that, the prevalence of mental illness in pregnancy is very high. The epidemiological studies have clearly indicated the prevalence of mental illness in pregnant women is somewhere around 15 to 29%, my dear friend. That's a huge number. At the same time, pregnancy is at a high risk of relapse of pre-existing mental illness. So, what is it about? If you don't treat a mental illness during pregnancy, it has a negative health consequences both on the mother and also on the fetus. What are the negative consequences? The child have developmental problems over a period of time. Not only the physical development, but also the brain development. What about the mother? Mother will have a myriad of adverse pregnancy outcome. It can be early abortion, preeclampsia, eclampsia, and various other pregnancy-related complications. And you need to remember, psychotropic medications which are given during pregnancy can cross the placenta. These psychotropic medication, once it crosses the placenta, enters into the fetal circulation. This is based upon varying degree of characteristics of the medication and also the maternal physiology. Here we need to understand the risk and benefit. If you give medications, it can affect both the mother and the child. At the same time, if you give electroconvulsive therapy, it can have the effect of ECT, anesthesia, and muscle relaxant which is given during ECT. If you don't treat the mental illness during pregnancy, it has a severe consequences on the child, that is the fetus, and the mother. Now you need to weigh the risk versus benefit of providing ECT. Let's discuss about electroconvulsive therapy during pregnancy. Before we move into electroconvulsive therapy during pregnancy, we need to understand what are the changes which occurs during pregnancy. There are 5 important systems which gets affected during pregnancy. These are physiological changes. One is with regard to blood chemistry. Here, there will be increased clotting factors, increased fibrinolytic activity, iron deficiency, and anemia is very common in pregnant women. With regard to cardiovascular system, there will be hyperdynamic circulation, tachycardia, increased cardiac output, and increased stroke volume. With regard to respiratory system, and when the pregnancy increases over a period of time, then there will be displacement of diaphragm superiorly, decreased functional capacity of the lungs. There may be apnea, dyspnea, and hyperventilation. With regard to GI, there will be nausea, vomiting, heartburn, and acidity. The general changes which have been seen with regard to mood and behavioral changes are common during pregnancy. This you need to keep in mind before you give ECT in a pregnant woman. The official joint statement given by the American Psychiatric Association and the American College of OBG states that ECT should be considered as a safe, effective treatment option for severe psychiatric disorder and also in severe depression in pregnant women. However, there are no randomized controlled trial to know the efficacy of ECT in pregnant women and also the safety of these medications which are given during ECT and electroconvulsive therapy safety data. This is mainly because there are ethical and legal issues surrounding giving ECT in a pregnant woman. None of the regulatory bodies will approve to do RCTs with regard to ECT in pregnant women because it will affect both the mother and child. Hence, none of the regulatory bodies or institutional review bodies may not give permission to give ECT. However, there are data available with regard to case series, case studies, reviews, expert consensus guidelines have been available with regard to ECT during pregnancy. Safety data with regard to ECT during pregnancy is extrapolated from ECT use in non-pregnant women. And also, there are some studies with regard to, as I told, case series, which gives immense data with regard to ECT in pregnancy. Adverse effect of ECTs are similar in pregnancy and also in non-pregnant women. However, the physiological changes which I mentioned can cause some complications. And this need to be kept in mind before you post a pregnant woman for ECT. The seizures which occurs immediately after electroconvulsive therapy stimulation can increase the cardiac work, oxygen demand, and may lead to decreased perforation of the fetus. Pregnant women are at increased risk of aspiration and also iotocaval compression, that creates a decreased venous return to the body and also may cause hypoxia to the fetus. In addition, pregnancy-related complications such as hypertensive disease, gestational diabetes, preeclampsia, eclampsia should be considered and taken into account before you post a pregnant woman for ECT. Further, the modified ECT will also add burden to the pregnant woman. That is because of seizure induction by electrical stimulation, anesthesia drugs, and muscle relaxant. These needs to be kept in mind before you post a pregnant woman for ECT. Let's understand about informed consent. We need to take a written informed consent from the pregnant woman. If the pregnant woman has severe mental illness and has an impaired mental capacity, in such a scenario, you need to take consent from the nominated representative or the family members. That is, proxy consent has to be taken. And you need to take consent for the course of ECT. The course of ECT in pregnancy is somewhere around 6 to 12 ECT, based upon the response, based upon the severity of illness. We will give ECT with regard to number of sessions. Please remember, once the patient improves, she can withdraw the consent, or else even the nominated representative can withdraw the consent before you give complete course of ECT. That means if the patient is receiving ECT and you have planned to give 7 ECTs, the patient improves and she regains capacity. At the third ECT, she can withdraw the consent. So my dear friends, please do respect if the patient has capacity, their choice, because the Mental Health Care Act of 2017 gives complete autonomy and also the liberty to the persons with mental illness if they have mental capacity. Let's understand what are the pre-ECT workup to be done in a pregnant woman. First and the foremost, the detailed evaluation, general physical examination, weight, BMI, ultrasound for abdomen has to be done, especially in pregnant women. Hemogram, biochemistry, check for dentures, loose tooth, capacitive consent to be administered, and if she has capacity, take consent from her. Other optional may be ECG, CT scan to rule out if there is any space occupying lesion if you suspect, X-ray lung pathology, and mini mental status examination. Please remember, CT scan and X-ray don't expose the pregnant woman unnecessarily, unless if you believe there is a lung pathology or if there is some issues with regard to space occupying lesion in the brain, then only expose the pregnant woman for CT scan or X-ray or any radiation. You need to keep this in mind. Don't send them routinely for X-ray and CT scan, my dear friends. Administration of H2 receptor antagonistic, prokinetic medication, proton pump inhibitors before the procedure reduces the risk of associated with aspiration and also acidity. This is very essential. Uteroplacental perfusion and fetal oxygenation can be optimized by prehydration with intravenous fluid, that is around 12 hours prior to ECT, left lateral positioning with a wedge of the pregnant woman during ECT, and pre-oxygenation need to be done. However, please don't do hyperventilation because this may cause vasoconstriction and the child may suffer or the fetus may suffer. Multidisciplinary care team should be available, that is psychiatrist, anesthetist, and OBG. Of course, the OBG will be a standby, and if it is invariably various guidelines advocate to give ECT in a general hospital setting where OBG specialist is available. However, in psychiatric hospital, having a OBG specialist standby will increase the rate of ECT phenomenally. Hence, many a time, if the patient is not in a third trimester, we can give ECT without the gynecologist. It is based upon the availability of the OBG specialist. In many developing countries, having a gynecologist as a standby is a luxury. Hence, you need to know the availability of resources, whether we can afford a gynecologist as a standby. It is not for one ECT, my dear friend. You are going to have a gynecologist for 8 to 12 ECTs. That means you'll be paying for a gynecologist during that period. Of course, it is the risk versus benefit, affordability, and availability of the gynecologist during that period plays a crucial role. Special consideration for risk factors need to be kept in mind. If it is a special pregnancy, spontaneous abortion need to be kept in mind, preterm labor, abruptio placenta, uteroplacental insufficiency, past history of medical termination of pregnancy, past history of immediate abortions. Risk factors need to be kept in mind. Avoid NSAIDs. Night before the ECT, administer 30 ml of 0.3 m sodium citrate to be given, and 6 to 8 hours of nil-orally is very essential. If the pregnant woman is on some medication, she can take the medication prior to 2 hours of ECT with a clear water. Let's understand high-risk pregnancy and ECT. If a late term or high risk, use continual fetal monitoring during ECT. If a patient is at high risk of preterm labor or other complication, ECT can be performed in a labor room or in a delivery operating room, so that if there is any kind of complication, we can go for cesarean or for a normal labor. Obstetrician or the gynecologist should be aware of the timing of the ECT and also the months of pregnancy. If there is vaginal bleeding, please postpone the ECT unless you know the cause for bleeding. You need to make certain changes in the medication. Certain medications to be administered before ECT, and certain medication should be avoided, such as atropine should be avoided during pregnancy because the fetal heart rate variability can occur. Hence, glycopyrrolate will be considered as the drug of choice in a pregnant woman. Not only that, propofol is associated with shorter seizure without loss of efficacy may prevent fetal heart rate changes associated with prolonged seizure. So, you can choose these medicines wisely and on discussion with the anesthetist. Position of a pregnant woman during ECT. There is a risk of compression of vena cava and aorta during the gravid uterus. That means having a supine position, the gravid uterus can compress aorta and vena cava. The patient should be asked to acquire a left lateral position during ECT. This is achieved by placing a pillow or a wedge under the right hip that elevates up to 10 to 15 centimeter like this, my dear friend. Place a pillow under the right hip so that the elevation is around 10 to 15 centimeter. You can see the diagram here. Here the uterus can compress in a supine position on the aorta and the inferior vena cava. Hence, to avoid this compression, you need to put the pregnant woman in left lateral position by raising the right hip, my dear friends. Now let's discuss about induction of anesthesia in pregnant women. IV hydration prior to 12 hours before ECT to be considered. Either you can give linger lactate or normal saline. Pre-oxygenation to be done, but do not hyperventilate in a pregnant woman before giving ECT. Maternal secretion and bradycardia can be prevented by glycopyrrolate 2 mg rather than atropine. Induction should be considered by propofol 0.7 mg or 2 mg per kg body weight, or else you can choose methoxytol 0.5 to 1 mg per kg body weight. Muscle relaxant like succinylcholine in the dosage of 0.5 to 1.5 mg per kg can be chosen. Let's understand about the meta-analysis studies with regard to adverse effect of ECT on a pregnant woman. As you can see, there are 4 important studies have been considered. Miller 94, Anderson Reti in 2009, Likinis et al. In 2015, Pompili in 2014. These are the studies which looked into the adverse effect of ECT on a pregnant woman. The commonest, if you can look at, is abdominal pain. Further, very rarely fetal heart rate changes can be seen. Preterm delivery has been indicated. But however, my dear friends, the numbers are very, very less or a very minor in number. The rates of miscarriage, premature contraction, preterm labor were not significantly different from that of general population if you look into this meta-analysis. There have been no association of ECT with congenital anomalies, either morphologic, behavioral, or neurocognitive disturbances in the child. That means by giving ECT, it will not affect the child or teratogenicity in the child. ECT is considered as reasonably safe, effective treatment, alternative to psychotropic medication, my dear friend. To summarize the findings of these 4 meta-analyses, the most common adverse effect which were noted is which are temporary in nature, self-limited fetal heart rate changes, contractions which rarely progress to labor. However, the rates of vaginal bleeding, placental abruptia, prolonged fetal heart rate change abnormalities, preterm delivery, or stillbirth do not increase in patients who undergo ECT, my dear friends. ECT during pregnancy, to summarize, the adverse effect of pregnancy, the adverse effect of ECT in pregnancy is similar to the ECT in a non-pregnant woman. There have been no association between ECT and congenital anomalies in the child. ECT is a reasonably safe and effective treatment in pregnant women who is suffering from severe psychiatric illness, my dear friends. Let's look into ECT in postpartum period, that is after the childbirth to 1 year. But however, based upon various definition, various researcher and physician, postpartum period can be up to 1 year. WHO says after the birth to 6 weeks, and certain researchers say that it is from 3 months up to it can be extended up to 1 year. However, in this video I'll be considering up to 1 year. Postpartum psychiatric illnesses is very common, such as postpartum blues can occur up to 50 to 60%. They are self-limiting, need not worry. some amount of psychosocial counseling, supportive therapy, and availability of family members can be very helpful and to decrease the postpartum blues. However, postpartum depression and postpartum psychosis are life threatening both to the mother and also to the child. Apart from this new onset psychiatric disorder, postpartum period is associated with high rates of psychiatric illness. Pre-existing psychiatric illnesses can relapse. This you need to keep in mind, my dear friend. If a lady had a mental illness before the childbirth, there is a high possibility it will relapse during postpartum period. At the postpartum period, you need to understand there are behavioral changes which occur in the pregnant woman. She can become violent, suicidal, homicidal ideas towards the child, infanticide risk, impaired mother and infant-child bonding, catatonia, food refusal. These are the various cascading events which can occur during postpartum, affecting both the mother and the child. Postpartum and psychiatric illness can have a long-term effect both on the mother and the child. Further, the psychotropic medication exposure can have an impact on the child because most of the psychotropic medication are secreted in the breast milk. That means you need to be very careful when you prescribe medication to the pregnant woman. Literature is slowly accumulating with regard to mental illness in pregnancy and postpartum period, which can affect the infant or the fetus. Postpartum period and the treatment. There are no randomized controlled trial of use of ECT during postpartum period. Most of them are case series, case reports, review, and also clinical practice guideline, and some of them are expert consensus guideline. Given that the ECT predates the psychopharmacological medications, that is, ECT is around 8 to 9 decades old, whereas medication is hardly 6 to 7 decades old. Comparing both medication and ECT, ECT is found to be very safer both during pregnancy and also during the postpartum period. If you look at the Indian studies with regard to ECT in postpartum studies, there are two important studies which can be seen. Agarwal et al. In 1997 published in International Journal of Social Psychiatry clearly reported about 192 postpartum women who received ECT, and they said that 42% of the postpartum women received ECT. Similar study which was done in Niemann's, Babu and his colleagues clearly reported that 78 patients received ECT. That means 44% of the postpartum patient received ECT. That means somewhere around 40 to 50% of the postpartum period may require ECT. These studies, both of them clearly said that ECT during postpartum period is safe and effective both for the mother and the child. Let's look into the review articles across the globe. Review articles suggest that use of ECT as a first line of treatment in postpartum period onset of illness can be given for rapid resolution of symptom is required. That means if the postpartum lady is highly suicidal or homicidal or infanticidal, in such a scenario you can choose ECT. Further, severe psychiatric illness, poor response to medication can be considered as a treatment of choice with regard to ECT. It is sensible choice given the concern with regard to medication exposure to the fetus or the child. ECT and postpartum law. Let's understand what does it say. You need to understand Mental Health Care Act of 2007 regulates electroconvulsive therapy. It clearly says that in section 95, unmodified ECT is completely prohibited. Not only that, ECT cannot be used as an emergency treatment. ECT to be given should be modified ECT and it should be with informed consent. Not only that, Section 21 of Mental Health Care Act clearly talks about a right to equality and non-discrimination. What does it mean? Mental Health Care Act of 2017 with regard to ECT and Section 21 talks about admission of a postpartum mother to a mental health establishment. What does it say? A child under the age of 3 years of a woman receiving care, treatment, and rehabilitation should not be separated from the mother and the child. That means if the child is less than 3 years, you need to have a strong reason to separate, and the reason should be documented, and a psychiatrist has to opine that mother is highly violent, or else she is a risk towards the child, or else she may become violent and infanticide is there, and you need to separate the child in the best interest of the and safety of the child. That needs to be documented, provided the woman shall also have access to the child under the supervision of the staff. That means just because you separated the mother and child, you cannot keep the child away from the mother endlessly. The mother will have access to the child under supervision. The decision to separate the mother from the child shall be reviewed every 15 days, my dear friend. And if it crosses more than 30 days of separation between the mother and child, you need to take the permission from the state mental authority, my dear friend. It is not even Mental Health Review Board. The Mental Health Care Act section 21 is very clear. You need to take the permission from the state mental authority. To conclude, my dear friend, although electroconvulsive therapy is a controversial treatment, it is there since past 8 to 9 decades. It has withstood the scrutiny of human rights activist, community, researcher, and clinician. It continues to be one of the effective treatment available at this point of time, my dear friend. ECT is found to be safe and effective both during pregnancy and postpartum period. There are few persons with severe mental illness, such as having homicidal ideas, infanticidal ideas, suicidal ideas, unable to take care of themselves, and also not able to take care of the child, and catatonic patients will definitely benefit with ECT. Thank you very much for your valuable time. Stay safe.